So we go to the next speaker, which I suppose Professor Cheng Hua, with title more metamorphosis, finding the good spot in the antithrombotic therapy after bifurcation PCI, please.
Good afternoon, ladies and gentlemen. The first of all, thank you for your great lecture about technique in bifurcation PCI. And now I don't talk more about technique for bifurcation PCI. And after you successful with bifurcation stenting, how to protect the lesion, how to protect the stent, and protect your patient. And now I would like to report to find out one question. How to optimize for patient and how to find a response in antiplatelet therapy after bifurcation PCI. I would like to talk about my problems. I will cover 3 problems. The first upon more why more metal, more risk, and last second I would like to find sweet spot in antiplatelet therapy in bifurcation PCI. First question: bifurcation are common. So nowadays, overall, in CCS and ACS, bifurcation lesion around 15 and to 20%. In ACS with left-man, bifurcation lesion sometimes to 20 to 55%. So that's I think in daily practice you can make bifurcation BCI every day. In my cath lab we have 3 or 4 bifurcation lesion a day. So that is very common in clinical practice. And last second, why bifurcation PCI is a high risk thrombosis stent. So this one some theory, some mechanism about thrombosis, the risk of stent. So if you put 2 stent technique, so more stress and more overlaps layer, so that's slower endothelial healing, and especially as the cadena, so slow share stress and flow these 2 bonds. So that's in this cadena, so platelets love this area very much. So they get exciting and increase activity. So that start causing the problem. So that with the patient with high risk, and nowadays we have a lot of major trial highlighting the risk associated with bifurcation PCI, with decay growth and SL trial. So increase target lesion failure and increase stent thrombosis risk. If the patient with the high risk thrombosis, the patient with diabetes, CKD, the patient with peripheral artery disease, the patient with multiple coronary artery disease, and young patient, and especially with patient with many stent and very calcification. If the patient with bifurcation and 2 stent, so the patient with high risk, the MACE with stroke, die, and myocardial infarction by 2 or 3 times. Ladies and gentlemen, this one a patient with ACS plus a bifurcation and 2 stent, so that the patient with triple risk thrombosis. So we call that a perfect thrombosis system. So that in this patient, we have to protest the stent. So that sometimes we need umbrella to protect the patient. So that in this case, we need a strong depth and duration depth for patient. Sometimes we have to duration more 12 months to protect the patient. But in this patient with high risk thrombosis, you have to use a potent antiplatelet so that the patient associated with high platelet. Platelet also important because uh, when major platelet is similarly mortality as myocardial infarction, and the patient with high platelet double even a risk. So that we need in daily practice we need a balance between ischemic and platelet. Uh, and now let's move to therapy. This is some recommendation from ACC and recommendation to local from Vietnam. This one, DAF surgery post PCI with ACS. Daily practice, the patient with ACS in Vietnam, we use DAF with a strong antiplatelet, prasugrel and ticagrelor plus aspirin, minimum 12 months. But with some patients with high platelet risk, we can stop aspirin early. 3 months after that, we can stop aspirin. But we can use sock DAP in some patients with high platelet, so that the message DAP is not one size fits all. In daily practice, how to optimize anti-thrombotic therapy, both PCI in bifurcation. In my cath lab, if the patient with sample lesion with one stent technique, provision is stenting, uh, uh, it depends the CCS or ACS. With CCS, we can use DAP 6 months, but with ACS, we can use DAP minimum 12 months. And sometimes with the patient with high platelet, sample lesion, and small size brain, and good imaging in IVERS, we can use soft DAP, and we can stop aspirin early after 1 month or 3 months. Uh, but uh, but if patient if it's complex PCI with the technique to stand decay cross stop cool-loss, so more mental, so higher some stand thrombosis, so that in this case we need longer depth, minimum 12 months. But some patient with very high risk thrombosis, we can duration depth more than one year. If the patient left main bifurcation stenting, CTO, heavy calcification, and big-side brain, long stent overlap, and suboptimal result in IVERS OCT, so that we can prolong that for patient to protect the patient and protect the stent. I show you the first case with high thrombosis risk. This one young man ACS with non-STEMI. The patient with left main bifurcation 111. So that's because the patient very young. So we have to optimize the technique with decay cross two stent. So that's this patient with long double layer metal segment, so that we decide choose ticagrelor plus aspirin, and we prolonged duration death more 1 year. In other hand, we have a woman 78 years old, CCS with gastrointestinal bleeding history, and the patient with only one stent provisional LED and diagonal, and I was very excellent optimized. The patient we decide to shock up, and we stop aspirin after treatment. Finally, uh, for, when bifurcation PCI, so real more mental higher thrombosis, so that with two stent surgery need strong and longer depth, but the patient with low risk and high blood pressure, you can decide with short dap and single dap, single and antiplatelet after 1 or 3 months. And through switch spots, so we have to individual therapy. It depends the anatomy, 1 or 2 stent, clinical setting, CCS or ADS, and it depends the high blood pressure, and sometimes we have to depend result optimization. So with bifurcation PCI, more metal, more risk. So I think less E more. Sometimes DAP, strong DAP, and duration of DAP help us protect the patient, protect the lesion, and protect stent. Thank you very much for your attention.
Thank you, Professor Changhua. It was a very interesting topic as a daily basis. I believe that is individualized among patient per patients. So may I ask our panelists, what is your common practice in your lab? If you find the patient with ACS and getting complex thing, and then you know that in Southeast Asia, most of the patient coming with HBR. So what is your strategy? Maybe Dr. Fong?
Thank you, Dr. Hoa. The presentation very excellent. I have a question for you. In the lesion bifurcation, when you optimize in the technique, with the IVUS, with the expansion to stent, and you use the less layer stent, you can stop the DIPT more soon. Maybe 6 months or 3 months.
Yeah, thank you for your question. It's a good question. I think in daily practice nowadays, in my cath lab, I use IVUS for 100% for patient, so that we protect the patient, and after imaging we can post dilate and optimize the lesion. So that in this case, with a shock dap, I think after treatment we can stop aspirin. But nowadays, if possible, I choose one stent for patient. It's the better. Yeah. And how about your Caleb?
Sorry. So my apologies. Yeah, I think it all depends on how confident you are with your result after you've done your angioplasty. And I think in our cath lab, we try our best to go 100% IVUS if we can. And if I'm comfortable with that, then I think I would be happy to stick with, for ACS patients, just 1 year. And if I'm happy with the results that I've seen in my bifurcation left main, I could go 6 to 12 months. If it is an ISR that we've gone back into, and we were discussing that earlier as well, then I think we would go for a longer period of DAPT.
Thank you.
In my center, so we practice that depends on the HBR risk, and I think most of these type of patient we will put them on the shorter DAPT type of stents. I mean, those stents like Onyx who has HBR data. So we go for 6 months probably with a DAPT and then.
Yeah, thank you very much. I totally agree with you.
Okay, thank you.